Good afternoon. This is Swati Sehgal, and I really appreciate the invitation to give a talk on long-term quality of life issues post-heart transplant. These are the objectives of my talk. I would like to highlight some historical pearls in the area of heart transplant, show you some fast facts about pediatric heart transplant in the US, discuss the functional status and quality of life literature, describe our own experience in the area of quality of life, and share some photos and pictures of our transplant recipients. First, So this was the first ever heart transplant that was performed at University of Mississippi Medical Center in 1964. This was a chimpanzee heart used for a human and did not go very well. This is a book I would recommend for anybody who is in the heart transplant field or is aspiring to be in the heart transplant field. Every second counts, the race to transplant the first human heart. This book describes how close people were to being the first person or the first surgeon to transplant the human heart. And who won? Christian Bernard. We all know Christian Bernard was the first surgeon to do a human-to-human heart transplant in 1967. This was in South Africa. However, I would say that his success was a result of many years of early pioneering experimental work by Alexis Carrel, Frank Mann, Norman Shumway, and Richard Lower, who were esteemed surgeons of their times. These are the pioneers who paved the way for the success of heart transplant, the unsung heroes like there are in every field. When was the first pediatric? Just 3 days later, in 1967, at Maimonides Medical Center in New York. Dr. Kantrowitz was the surgeon who did that infant heart transplant, and the donor heart was procured from an infant with anencephaly. On the right, on the top, you'll see the telegram that was sent throughout the country to be able to find a donor that would be suitable for the infant with tricuspid atresia who was waiting for a life-saving heart transplant. And on the bottom is the picture of the team who did that first transplant. This infant lived for 6.5 hours. This was America's first heart transplant. And then for 2 decades, there was a lull in the area of heart transplant because people didn't believe it would be successful. Until in the 1980s, Dr. Leonard Bailey conducted this first baboon heart transplant in a child who had hypoplastic left heart syndrome. And this was before the Norwood and the 3-stage palliation of single ventricle surgeries had become the norm. This baby lived for 21 days and died of multi-organ failure. But within a year, Dr. Bailey performed an infant-to-infant heart transplant, which was very successful, and that baby lived into his mid-20s. Some fast facts about pediatric heart transplants. About 500 pediatric heart transplants are performed each year in the North American continent. Most infants receive a heart transplant for congenital heart disease, and most adolescents receive a transplant for cardiomyopathy. The 5-year overall survival is surpassing 90%, and for infants, 50% are alive at 25 years after heart transplant. As you can see on the right, every year in the last 4 years, we've reached about 500 transplants in the US. There was a little dip in the year 2020, as you know, with the COVID pandemic. We had a shortage of organs that could be donated for pediatric heart transplant. The pediatric heart transplant program at Children's Hospital of Michigan, where I am, started in 1998. And so next year will be our 25th anniversary. We have done 118 transplants so far, with an average of about 5 to 7 every year. We are currently following 45 patients outpatient, and these patients are taken care of by a very well-trained multidisciplinary team, which includes not just the transplant cardiologist, but the nurse practitioners, social worker, transplant nutritionist, and transplant psychologist. And in the recent years, we've established a formal transition process for our young adults to transition them smoothly and successfully to an adult heart transplant center. And we've transitioned 9 in the last 5 years with that process. I want to take a moment to highlight the milestones in the area of pediatric heart transplant that we've seen since the very beginning. In the top left graph, you will see how the survival or the median survival has improved since we first started doing heart transplants in the 70s and 80s. And to this day now in 2022, where we've seen an attempt at doing world's first combined heart and thymus procedure to obviate the need for immunosuppression, to transporting a donor heart in a machine, to attempting xenotransplantation, which is transplanting a pig heart with modified genes to suit a human, performed early this year. And then I take a pause and say, but what about quality of life? The World Health Organization defines quality of life as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And as you all know, quality of life is unique to all of us. Taking a step back to the functional status as opposed to quality of life. There are performance scales laid out by Lansky and Karnofsky, which define the functional status of an individual. Lansky scale is for kids less than 16 years of age, and Karnofsky is for more than 16-year-olds. And as you can tell, 100% score means they're fully active with no limitations. A score of 90% would mean minor restriction with strenuous exercise, and a score of 80% would mean that the person tires more easily but is active. And as you go down, the degree of restriction goes up. So in terms of functional status, what does the literature say? And this, I think this study is representative of a large number of children in the United States who received a heart transplant and studying their functional status. They included 1,600 children, and at the one-year assessment, 64% of them were fully active with no limitations. 21% had minor limitations with strenuous activity, which gave them a score of 90%. Putting them together, 85% of the children had really good functional status. They also did a regression procedure and discovered that the variables for abnormal functional status at 1 year post-transplant included greater than 18 years of age, Black race, if they were supported with more than just inotropes at heart transplant, so if there was a mechanical support device used, hospitalization status at heart transplant, chronic steroid use at heart transplant, and treatment for early rejection. And they concluded that among US children who survive at least 1 year after heart transplant, functional status is excellent for majority of the patients. And heart transplant is associated with substantial improvement in functional status in most children. This graph represents the same data in a graphical manner. Here in panel A is at heart transplant listing. So you see the functional status distributed from 10 to 1. Similarly, at heart transplant, the functional status is not very different. However, 1 year post-transplant after rehabilitation and early recovery, a good chunk of the patients have really good functional status. Coming back to this graph here, which shows a significant improvement in the median graft survival from 1970 to 2001, based on all the discoveries and inventions and advances in the field, whether it is surgical or prevention of rejection. But despite this improvement in outcomes, there are factors that limit the quality of life of these patients. And these factors include prolonged hospitalization in critical patients pre-transplant, post-transplant ICU stay, setbacks, complications, social support for caregivers, and then the rigorous post-cardiac transplant regimen, not to just end at medications, rigorous outpatient clinic visit schedule, frequent cardiac catheterizations, and lifelong immunosuppression medications and their side effects. As you all are aware, there's this on the left, there's a sample regimen, medication regimen post-transplant that our patients typically go home on. And on the right is a clinic schedule for the first month post-transplant, and you see how busy it is. And this does not even include physical rehabilitation. Sometimes a lot of our patients need outpatient rehab. What does the literature say about quality of life in these patients? First of all, there is limited research in this area. There is gap in reporting quality of life in pediatric cardiac transplant recipients. There is gap in reporting from exclusively urban settings in case of the US. And then it is health-related quality of life that's most frequently measured, which, as you all know, is only one aspect of quality of life. The good thing, though, is that there is agreement in the definition of quality of life. Everybody agrees it's not just the absence of disease. And then SPEEDS QL is the most frequently used tool for measurement. So there's uniformity in how it gets measured in most studies. And then all studies agreed that transplantation was difficult, challenging, and not without complications. and the recurrent theme of exchanging one chronic problem for another prevails. So why is it important to assess quality of life? Firstly, I think that's the goal of offering a heart transplant. As you all will agree, it's not just to increase the longevity of somebody's life that we offer a heart transplant, especially if you think we are exchanging one chronic problem for another. We would hope that we are at least providing them with a better quality of life in that situation. But the other important reasons also are that the results of quality of life measurement will assist the transplant team in transplant education. They will help identify social services that would benefit the family. It also would help allow for earlier recognition of transplant patients and families in crisis. However, no formal quality of life assessment. Just to highlight some of the features of the research that has been conducted from different countries in the world. So this study is from the US, and they are trying to compare the quality of life in pediatric heart transplant recipients with or without heart disease, with children with or without heart disease. And their conclusion was that although pediatric heart transplant recipients experience significant symptomatic improvement, they remain at risk for impaired psychosocial quality of life. And it is similar to children with residual or palliated heart disease. And they also conclude that assessment is needed to identify children at risk and improve psychosocial outcomes. Another study from France, they did a cross-sectional study to identify quality of life of transplanted children and their parents. They included all solid organs here, and the main conclusion was that transplanted children and their families reported a fairly preserved quality of life compared to children with other chronic health conditions. And they also determined some modulators. They said the main modulators that decrease quality of life were residual treatment level. So for example, if somebody had organ dysfunction despite getting a transplant, medication switches, which could be a surrogate for them not doing well and requiring a lot of medication regimen changes, and then the presence of another regular treatment. So for example, in our heart transplant population, if they also develop diabetes, that definitely impairs their quality of life. Another study from Canada, they looked at health-related quality of life after pediatric heart transplantation in early childhood, and they reported that health-related quality of life is significantly lower in transplanted children compared to population norms, and not just with the normal population, but also compared to children with chronic conditions and children with congenital heart disease. This study highlights the importance of post-traumatic stress as a determinant of quality of life in pediatric solid organ recipients, and included again all solid organ transplant recipients. And they concluded that living with end-stage organ failure is associated with an accumulation of traumatic medical events. For example, chronic dialysis in a kidney transplant recipient. And so the PTSD from that correlated with lower quality of life after transplant. And their conclusion was that trauma symptoms are a major modifiable risk factor for lower self-perceived quality of life and represent a potentially important target for post-transplant rehabilitation. I would like to describe a study at our center. One of our nurse practitioners spearheaded this study. She used the PEDS Quality of Life QL3 transplant module, which is a validated tool. And she used a parallel child report and parent proxy report for children who were 5 to 18 years of age, and parent proxy report for younger children who were 2 to 4 years of age. In this tool, higher scores on the transplant module indicate higher quality of life. Her study population included 24 recipients and 22 caregivers, and overall quality of life score median was 81, which is really good technically speaking, with a range of 53 to 100. And one of the findings was that the caregiver quality of life scores were higher than the recipients, except in the area of anxiety. So, when there were psychosocial domains for caregivers, they worried more. They had more worry or anxiety about their child's future and scored less in that domain. Some of the common themes that she found during her assessment for poor scores was one related to pain and hurt. So the frequency of blood draws, cardiac catheterization with biopsies and things like that. There were poor scores related to worry whether the meds were working or not, and worry whether something is wrong with them or their heart. And also in relation to peer relations, especially in older kids and teenagers. They worried about being treated differently. They said people don't understand what I've been through, and they had a difficult time talking about transplant with others. The take-home message for our team from this research was that we needed universal implementation of quality of life assessment in our transplant clinic, and not just one time. We need to follow longitudinally to allow for earlier recognition of concerns and families in crisis. This has led to improvement in finding psychosocial support for our patients. So we have started implementing or seeking psychology services for at-risk individuals more often. There are trauma psych services, counseling services available through the general pediatric clinic, and we've had a few adolescents enroll in that and really gain some grounds in terms of their psychological health. And then we're working on support groups, and this has been a little challenge with all the rules and regulations within the hospital, but online support groups or in-person support groups would be a really good addition to this kind of support system. And then we encourage participation in organ procurement organization and hospital events for these patients and families. And there are transplant camps and transplant games, not through the hospital, but through the community, that really go a long way in making sure that these children can live healthier and normal lives. So how do you improve your daily quality of life? When I was researching this, I came this advertisement for an advanced practice provider. This is not our institute, it's from University of Wisconsin. And the advertisement goes, this was, seeking an advanced practice provider for their institute and asking for making a difference to improve quality of life for transplant patients. And I think there is a very important role that our nurse practitioners, our advanced practice providers play in making sure that we as clinicians don't forget quality of life. We sometimes get so busy and focused on the medical aspects of transplant and the complications, or looking at the labs and making sure that there is no rejection and no coronary abnormalities and this and that we forget the day-to-day things that make a difference in how they perceive their quality of life is as a patient. And so this is not our nurse practitioner. This one is. As you can tell, this is one of our patients, transplant recipients on the left. This was like his discharge day, and on the right is not his mom. It's one of our nurse practitioners, Lauren. And that's what they do. They are the ones who not just take care of the clinical aspects of their care, but make sure that we as clinicians don't forget about the fun things in life. So in our hospital, we've had this tradition of clapping out patients who go home after transplant. And as you can see, everybody lines up in the hallway in the ICU, and we clap out the patients, felicitating how well they've done and how courageous they've been going through this whole process, and it really makes them proud. This is another picture of a graduate from the rehab unit. He pretty much stayed 1 year pre-transplant because of severe heart failure, and 6 months post-transplant recovering from that, and had to also go to the inpatient rehab unit for a few weeks. So this is how he was discharged from our hospital. The transplant camp that I was talking about is a really blessing for our transplant families. And as you can see some pictures from the fun they have at the transplant camp. This is a 7-day camp that the kids attend by their own. You have to be 7 or older to attend these camps, and it's a week full of fun activities with clinicians there who volunteer to make sure that the kids are safe and get their medications on time and such. This is another one of our patients. He's 21 now. He got a transplant at 3 months of age for a congenital heart disease. He's a car enthusiast. From what I was told, he buys old junk cars and turns them over. He's a mechanic too, so he knows all the things about the cars, and he turns them into cool, fun cars. Another one of our patients here. She loves the outdoors. She's 8 years old now. This patient here in the middle was a field hockey goalie, and she had dilated cardiomyopathy from a familial genetic cardiomyopathy gene. And as soon as she recovered from her early post-transplant phase, she wanted to go back to being a goalie. And we usually encourage patients to wait at least a year post-transplant and then, let them go out and play and do whatever they would like in terms of sports participation. But she was so intent on going back at 9 months post-transplant. We had her undergo an exercise stress test, and she did great. And because being a goalie is not as intense as other players in the hockey team, I think we reluctantly but happily agreed for her to go back, and she was really happy to be able to do what she wanted to do. Some of the activities I would like to highlight, this was like a young chef contest where local chefs from the Detroit area paired up with the kids with chronic illnesses and heart transplant. The one in the red shirt here is one of our heart transplant recipients, and they did a competition of who made the best dish. And this was covered in the news, and some of our transplant team members could attend. It was a fun event. Some other pictures of other transplant recipients that we've had, just want to highlight that their smiles and their normalcy, as much as we can achieve, is in the inspiration for us and motivates us in the stressful most times. And I like to go back to these pictures and helps me keep going. I would like to end with this quote from Charles Darwin. It is not the strongest of the species that survives, nor the most intelligent that survives. It's the one that is the most adaptable to change.